I'm going to be speaking to you about innovations in the preoperative assessment of the presbyopic cataract and refractive patient and how we do this at the Wellington Eye Clinic. These are my financial disclosures, and those that are relevant for this talk are Alcon and Vivior. I don't think that anyone would disagree that the past 18 months have been dramatic in terms of the changes. Consumers and patients are spending discretionary income on themselves. Healthcare and well-being have been moved up the priority list. Masks have driven demand for refractive and refractive cataract surgery, and advanced technology IOLs are increasing at a pace not seen before. To keep this momentum going, we need to ensure a seamless patient experience, procedure safety, efficacious outcomes, and high patient satisfaction. I've divided these innovations in preoperative assessment into the changes that COVID brought about in terms of appointments, IOL power determination, refractive target, and IOL design selection, other factors helping us prepare for success, and then informed consent, specifically nowadays including bilateral simultaneous cataract surgery or immediately sequential bilateral cataract surgery. COVID changed our routines, and what we need to do is make it easy to do business with us. Make the appointment process as simple as it is to do banking, booking a restaurant, booking a flight, or a hotel. Do the first part of the consultation virtually wherever possible, and this funnels patients that are serious about surgery into the clinic. And then the medical history form should be completed and should be easy to submit from a phone, a tablet, or a laptop. Refractive cataract surgery and the success of IOLs hinges heavily on accurate outcomes, and artificial intelligence IOL formulas are providing the best refractive outcomes. This is the likes of Hill RBF, based solely on big data, or Kane, Alpha QS2, Pearl DGS, or the Ladas Super formula, using a number of ocular measurements as well as AI to provide the most accurate results we've seen to date in terms of IOL power calculations. One of the biggest innovations in preoperative assessment in my personal experience has been the use of objective data to determine refractive targets when we're doing blended vision, or IOL design when we're doing advanced technology IOLs. And this objective data is so useful because it's very educational, it's very accurate, it's personal. It helps us to get the best fit for the most appropriate refractive target when doing blended vision, and to choose the most appropriate IOL when using IOLs. Data bias is all around us. If we just think about the anatomical, physiological, and behavioral differences between men and women, we get to realize that designing an IOL for both simply doesn't make sense. We need to personalize our technology to the patient's needs. So we have three options to help our patients select the best option. One is an interview or discussion. The second is the Dell questionnaire or something similar. And the third is objective visual data. The interview's been around for a long time, but it is subjective. Some patients are not good historians. Some doctors are not good listeners. It's time consuming. There's potential for misunderstanding, but it's certainly better than having no information. Of the questionnaires that are available, the Dell questionnaire is best known. Ask about the visual wish list. Where would you like to see well without glasses? Where are you willing to wear spectacles? Do you do a lot of night driving? Are you prepared to pay for advanced technology IOLs? And are you easygoing versus a perfectionist? I want to, however, make the case for objective data. It's objective. It is collected over a 36-hour minimum time frame. It is collected in the patient's home and workspace, so very personal and specific to them, and it measures much more than an interview history or questionnaire can provide. Subjective assessments such as in-depth interviews and questionnaires can be replaced by objective visual data obtained by a device such as this worn on your spectacles and gathering data. And this visual behavior monitor measurements include working distances, ambient lighting, and the head position of the patient. The Vivior monitor objectively measures patient behavior and matches it to the performance properties of a range of IOLs to compare monofocal, bifocal, EDOF, and trifocal IOLs, and to see how each of these modalities adds functionality to the baseline. The data defaults to showing what a generic monofocal at emmetropia would provide this particular patient. And in this case, this patient is without glasses for 45% of the time, and mostly for distance functions. It defaults to the generic monofocal, but then a pop-down or pull-down menu appears with every IOL with a published defocus curve, mix and match, monovision, and different target offsets.
I'm going to now look at a patient file, and we can see that this patient acquired data on 4 weekdays. We can switch any day off if we think it is unrepresentative, but we tend to include them all. We now look at the summary, and we see the overall defocus curve. This is information collected over 42 hours. We see that 48% was at intermediate, 20% at far, and 32% at near, 74% in good light, and 22% in low light. We can also see the patient's position, 94% straight ahead, most of the vision straight ahead too, but 35% downwards. And this person was 21% of the time was active while wearing the device. Now, if this person were to get a monofocal IOL, they would be free of glasses for 18% of the day, and this unshaded area would be where they would need glasses. And now what the device does is it automatically looks at all the IOLs that are available and ranks them from the best fit to the weakest fit. So in this particular case, it's the AT least that provides the most complete fit, and adds 78% to the defocus curve. So in this case, this person's without glasses all the time. They're 20/25 or better where it's shaded, and where they're not, they're slightly less good than 20/25, but that still means they're seeing pretty well. The next best lens of here is a fine vision trifocal, adding 76%, and then the Alcon Panoptics adding 75%. And when they're so close, you make your decision based on, first of all, what's available and the platform you like. But now look at this. Vivity at one eye at emmetropia, one eye at minus 0.75, providing 67% increased vision with the need for glasses just for small print. Now, if you have any concerns with a diffractive multifocal for nighttime driving, then this is a super solution. What about something like regular blended vision? So here's regular blended vision, and what this is doing is one eye at 0, one eye at minus 175. This too provides a very, very good overall defocus curve. Of course, you've now got to consider the fact that the two eyes are quite different, and you might have to deal with anisometropia, where with the likes of Vivity, the difference is much smaller. And if we now go to way down the page, something like the AcrySoft Restore for this particular patient. So for this particular patient's defocus curve, the AcrySoft Restore 2.5 is only adding 2% functionality, yet adds all of the issues with dysphotopsia and night halos and glare. So you can see why in the past patients might have been unhappy with a certain outcome because it did little for them, yet they had the dysphotopsia. Now when you go and match the patient's exact needs with the IOL that best fits those needs, you've got a much better chance of being successful.
This quick example will show the power of Vivior. So this particular The pull-down menu now shows when we implant a trifocal, this provides the greatest amount of additional functionality at 65%. And the only area not doing well is at 1 meter, where the vision would not be 20/25, but probably 20/30. The next best solution for this particular patient is the Acrosoft Vivior lens with the dominant eye implanted for emetropia and the non-dominant eye at minus 0.75, increasing functionality by 58%. And now, looking at monovision, with the dominant eye at emetropia and the non-dominant eye at minus 175, this provides a very good defocus curve that matches the patient's needs pretty well and increases functionality by 56%. So if this patient rated blended vision or monovision well, this is a real possibility for this patient. And then finally, just to explain how this technology can help us understand previous outcomes, for this very same patient, had a bifocal IOL been implanted, it would only increase functionality by 37%. There'd be a big gap in the intermediate range, and we can now understand why many patients were unsatisfied with previous versions of multifocal IOLs. In further preparing for success, we need to make sure that the ocular surface is pristine. Unlike this case, we need to exclude poor topographic and tomographic cases. We need to ensure that the OCT of the macula and optic nerve are normal. We need to make sure that the vitreous is healthy, and we need to make sure that the peripheral retina is normal.
Right, so I'm going to show you what the various options mean. Let's say this is distance looking out the window over there. Intermediate is looking at the computer screen in front of us, and near is looking at your phone or a book. If you target both eyes at 0, what you're going to have is you're going to have distance vision without glasses for both eyes, but you're going to need glasses for the shaded area, so for intermediate and for near vision. If you do something like blended vision at 0 minus 1, you'll have distance vision covered with one eye, you'll have computer vision covered with the other, but you're going to need glasses for reading. If you do 0 minus 2, that's going to give you distance vision with one eye. There's going to be a gap for the computer screen. You'll have to come closer to it, but you'll have reading vision, so there'll be a gap over here. And this can be achieved with standard lenses, standard IOLs. If you decide you want to go with something a bit more, we can look at a trifocal. And with the trifocal, you have these peaks of vision. There's a peak for distance, there's a peak for intermediate, there's a peak for near. So these targets are hit very well. You can see those well. But because of these troughs, you'll end up having halos around lights. And this disappears for most people, but for 3% of our patients tell us that they don't want to drive at night. When we ask them if they'd like to switch back to a lens like this, they say no, because they value the reading vision more and they don't drive much at night. So anyone who needs to drive a lot at night, we sort of avoid this. And then the last lens that we use a lot nowadays is an EDOF. We specifically use the Vivior lens because this has no glare and halos. And there are two choices there. The one is putting the lens in for distance in both eyes, and that automatically gives you distance and intermediate, but you need glasses up close. We very seldomly use it that way though. We normally use it as 0 minus 0.75. And now what happens is you have distance and intermediate in the one eye, and in the second eye you have intermediate and near. The only difference here is on the odd occasion you may find you need glasses for some things up close, but there's no glare and halos. And the person who tells me that they're a taxi driver who wants to drive at night, but they want the best range of vision in order to see road signs, to see their dashboard, and to even see their phone to bill the passenger, that's their best choice. The person who says, I don't drive at night and I want the most complete range of vision, they go with the trifocal. So go and think about this, and we'll speak about it again when we do your final consent.
The final piece of the puzzle involves informed consent, and today this includes looking at bilateral simultaneous surgery. We need to be sure that we understand our patient's needs. Consent needs to be informed. Patients need to know their options. The fact that the consent has been signed is not necessarily enough, and we need to document the thought process as to how a decision was reached in the clinical notes. In closing, This has really been a turning point in the uptake of AT IOLs during the pandemic. And we can increase the odds of success with meticulous planning and execution of procedures, with appropriate patient selection, with appropriate IOL power and IOL design selection, by opting for the procedure best suited to the patient, and ultimately by under-promising and over-delivering. If we want to surprise patients, we need to surprise them positively. Thank you for your kind attention and enjoy the rest of the session.